Good morning, everybody. Thank you for joining us for Asthma Grand Rounds today. And we have two really interesting and exciting speakers, Alejandro Diaz and Carrie Pistenmaa. And they're going to talk to us about novel imaging techniques and phenotypes in asthma and COPD. You can submit questions to our speakers by entering it into the chat. And we've changed the method for CME credit. It's now being awarded by the Mass General Brigham Office of Continuing Professional Development, which is mgbcpd@mgb.org. The method for getting in to do your CME credit has changed a little bit. So you need to go to cpd.partners.org, and you need to click login at the top of the page. If you're a member of the Mass General Brigham, you should choose Mass General Brigham Employee Login. And then you log in and you follow the instructions, which will tell you to put in your mobile number and give you a text that you're going to use in the future. If you are not a member of the Mass General Brigham family, then you choose Visitor Login and you complete the required fields. So basically, you go to cpd.partners.org and you either log in as a Mass General Brigham employee or you log in as a visitor login, and then you follow the issues. If you can write to MGBCPD at mgb.org, or you can write us if you have problems, and we'll be happy to help. Our talk today is novel imaging techniques and phenotypes in asthma and COPD. The learning objectives to describe how the use of chest CT imaging can define distinct phenotypes in asthma, how increased awareness of the rule of mucus plugging and pathophysiology of asthma and COPD have advanced our understanding of the disease and treatment of the disease, and identify other imaging modalities of potential use in understanding the pathobiology of asthma. Okay, and the SMS code for attendance is Jetstar to 857-214-277. But as I said, to get the CME credit, you need to establish an account at the Mass General site for CME. Chris and I helped plan this, and these are my conflicts, and these are the relevant financial relationships. Alejandro is an advisor to Sanofi, and Carrie has research support from AstraZeneca and Sanofi. If you have any technical problems during the live broadcast, send an email to bwhebcasttroubleshooting at partners.org. So we're going to have a talk from Alejandro and from Carrie on novel imaging techniques and phenotypes in asthma and COPD. Carrie is going to be our first speaker. Carrie is an assistant professor of medicine in the Division of Pulmonary Critical Care Medicine here at the Brigham. She has been interested in the area of chronic pulmonary diseases and emphysema, and she focuses on imaging, especially as it involves the pulmonary vasculature. And I'll introduce Alejandro when he's ready to speak. So Carrie, let me turn it over to you. We look forward to your talk.
Thank you so much. You guys can see my screen, I hope. So I am talking about novel imaging techniques and phenotypes in asthma. Thank you so much for having me. Let me make sure I can advance. Okay, I have some disclosures here, no conflicts that I'm aware of. The outline for today's talk, I'm going to start with an overview of imaging measures that we use in asthma and other airways diseases. And then I'll review some disease insights from imaging, some therapeutic insights, and then briefly touch on the omics of imaging in asthma, and then brief conclusions. So first, the imaging measures that we use in asthma and other lung disease. First, CT scans. These are most commonly done in research and in clinical care. And the main, I have a few slides all on CT scans. So the first one, we're just discussing that you can get the lung volumes from an inspiratory scan, and then often on an expiratory scan too. And so you can average the lung attenuation to get the mean lung density. And that's measured in Hounsfield units. So -1,000 is air. The closer you are to that, the more air is in the lungs, which is quite normal on the full inspiratory scan. On the expiratory scan, most of the air, not most, most, I guess most is accurate, of the air should exit the lungs. You're in a CT scanner, you don't have that long to expire, but you can get close to RV, and so residual volume. You should see a lot of ground glass on the expiratory scan. This scan here, there's definitely areas of gas trapping that are a little bit blacker, darker color, and that indicates that there's gas trapping there. And so that can be seen visually. It's read by radiologists visually. It can be measured quantitatively as the percent of volume of the lung that's below -850 Hounsfield units. And so then you can also compare the mean lung density between the expiratory CT scan and the inspiratory CT scan, and that gives you a measure of air trapping as well. The closer your expiratory scan is to the inspiratory, that's more air trapping. There are other ways to look at air trapping on CT. So you have the inspiratory and expiratory scans. The other ways, we're just using the entire CT scan. If you co-register the inspiratory and expiratory scans to each other, so line up voxel to voxel, or lung region to lung region, you can compare areas that change during from inspiration to expiration. And so functional small airways disease is the measure that we're most interested in here. And it refers to air trapping. It's an alternate measure of air trapping. And it's measuring areas that are normal on inspiration, but then they don't deflate normally on expiration. And so here, that's the yellow color here. They're on inspiration, they're lower attenuation, and on expiration, on inspiration, they're normal attenuation, and on expiration, they're lower than -856. And then the other areas, the red is hyperinflation or emphysema, and then the green is normal. And so you can see here how they can really regionalize the characteristics of the lung. So you can see the yellow here is the functional small airways disease, and green is normal, and then red is the areas of emphysema. And so then airways are another thing that can be measured on CT scan. It always overwhelms me how many different measures of the airways there are, and that on the right CT scan, you can measure them down to the 7th generation. And so with different imaging software, you can rotate the CT imaging and get to a cross-sectional view where you can measure the outer perimeter, the inner perimeter, the area of the airway, the area of the wall of the airway. This is the luminal airway, and then the wall airway here. And so there are different ways to standardize this. The different measures that people look at are the wall area percent, the lumen area percent, and then there are standardized measures that get to the, if you use all of the data from all of the airways and plot it on a line, you can look at what the standardized the wall area of an airway that has an inner perimeter of 10 millimeters. And then there's also debate on whether you should use an inner perimeter that might be affected by disease, or the outer perimeter, so there are other measures of the outer perimeter as well. And this is just a small number of the airways measures that are out there. Another thing that you can measure on CT scan, this one's a little bit more straightforward, but mucus plugs, you can see it visually on CT scans. There you can also, there are some measures I think you'll hear about in the next talk about some automated detections that can be done. This is one also just on inspiratory CT scans. This is a picture of the pulmonary vascular morphology. This is work from Raul San Jose Estepar's lab and George Washko. And this is a paper by Sam Ash. I'll actually touch on this a little bit later, but this is just a 3D reconstruction of the pulmonary vasculature. This is the arteries and the veins together of a healthy subject. And one of the things that we measure on this is vascular pruning. So the lower areas of small vessels, that's less than a cross-sectional area of 5 millimeters squared. And that's been looked at first in COPD and emphysema, and I'll share with you some information in asthma as well. And then the epicardial volumes of the heart, another thing that we can look at on the chest CT, non-contrast chest CT, just measuring the outer volumes of the heart. And then MRI, so not used as commonly in asthma, but traditional proton MRIs, when they're done in the lungs, there's a lower spatial resolution because air doesn't have a lot of signal on MRI. There are some sequences that have been developed that do improve the ability to visualize the lung parenchyma. This is not as commonly done though, so I think there's still some development. The use of contrast, so if you give gadolinium, you can measure the pulmonary vascular perfusion, microvascular perfusion, transit time through the lungs. So there's other options there. And the major benefit of MRI is the not using ionizing radiation. So hyperpolarized gas MRI is one of the more interesting uses of MRI in asthma. It's a measure of ventilation of the lungs. You can use either helium or xenon, and then the polarized gas is really just aligning the proton spin, which creates a really strong signal on MRI. So this is just a very pretty picture. This is on the top row. We have a healthy lung, 3 different segments, so different slices through. You can see that there's very homogeneous air distribution, gas distribution in the lungs. And down here we have a subject with asthma, and these black areas in the lung are ventilation defects, is what they are termed. And so you can sum up the volume of the lung that's affected by ventilation defects. And that's one of the measures that we use as well. There are some other imaging techniques I thought they deserved to mention, but I'm not going to talk about them further. So on bronchoscopy, you can use optical coherence tomography. It's a great group at M.P.H with Lita Hariri doing this. You can really visualize the airway as well as the surrounding lung using not near infrared light. And then on endobronchial ultrasound, you can also visualize the airways. Nitrogen 13 PET is a great way to measure ventilation and perfusion. It is limited by resolution and also more radiation exposure than regular CT scans. And then PET scans also have been used. FDG PETs have been used to assess metabolic activity in the lung. Mostly I've seen in COPD. And then just to mention, this is using CT data, but computational fluid dynamics is another method that you can use to assess how the airways impact disease. So there's models that look at airflow and turbulence, and you can look at particle deposition, which is of interest for not only medications and all the different formulations and where they may deposit in the lungs, but also air pollution and smoke exposure. So some insights from imaging. The airway measures that I mentioned, most of them correlate with lung function. So this is a study of patients with asthma, COPD, and then healthy. And you can see that there's a decrease as you go across the categories, and this is the percent wall area. So the greater your wall area, the thicker the airway wall, the more airflow obstruction. And so that's also what you're seeing here with the mean percent wall area and FEV1 predicted. And there's actually a stronger association here in the patients with asthma, where you have a lower FEV1 when there's a higher percent wall area. And then people have looked at, I like this study because they use lung airway biopsies and correlate that with the imaging measures. So this study performed airway biopsies and CT scans in 70 subjects at 2 sites. And here, just the luminal wall area here is on the left 2 plots, and the wall area percent is on the right plots. And this is epithelial thickness on the biopsy and airway smooth muscle percent. And they're not the strongest correlations. They are significant. There's only 70 subjects, but as you decrease the luminal area, there's an increasing epithelial thickness. And as you increase the wall area, there's an increasing epithelial thickness. So it's really what you would expect. And I think it's nice to see. and also associated with airway smooth muscle, as you would hope to see. There are also, in the same study, they looked at correlations with the biopsies and gas trapping. So this is the mean lung density, expiratory over inspiratory, and this is the percent of lung that's less than negative 856 Hounsfield units. So here, I'm going to do the airway smooth muscle, which, because we had that on the last slide. As you have an increasing gas trapping, there's more airway smooth muscle, and same direction of the association here, although a little bit weaker correlation. And then the vascularity on the airway biopsy also correlates with increasing gas trapping. And so this is using the functional small airways disease from the co-registered CT scans. This is the first slide I have of many from the Severe Asthma Research Program, which is a multi-center study in the United States, observational, following patients with asthma and particularly severe asthma. That's Dr. Israel and Dr. Levy are the site PIs for this study. And they did a lot of imaging, and so this is why I have a few slides, but these clusters of the subject population were defined by clinical definition. So from cluster 1 to 5, they go from mild to severe, with more persistent asthma throughout. This cluster 3 is more obese asthma. And I've pointed out here, these are pictures of the functional small airways disease, which is again in yellow. And then the percent of the lung that's occupied by the functional small airways disease I have highlighted here. So, not as much functional small airways disease until you get to cluster 3 and 4, a little bit increased, 24% of the lung compared to 18, 19. And then cluster 5 is really where you see there's a marked difference in the characterization of the lung here, with more small airways disease, some hyperinflation as well, and really a marked decrease in the normal lung. So this is just one way to show the difference across types of asthma. Air trapping has also been looked at regionally on these CT scans in SARP. And this study looked at each of the 19 segments of the lungs and categorized them as air trapped if there was more than 15% of that lung segment occupied by less than negative 856 Hounsfield units. And so they came up with a score, and the higher air trapping score was associated with a lower FEV1 over FVC, higher blood and sputum eosinophils, and then also with more mucus plugging. They did find that obesity modified the findings, and so patients with the BMI of greater than 30 had less widespread disease. That was over 12 segments affected, I think. And then they also found that that was more in the lower lobes. So patients with the BMI over 30 had fewer lower lobes affected by air trapping. And so I think we have to also consider that there may be an effect of body habitus on some of our imaging findings too, and keep that in mind when analyzing some of these smaller studies, because some of them are small. So mucus plugs, I think this is my only other slide on mucus plugs. That's something that Dr. Diaz will talk about more. But the CT scans in SARP-3 were reviewed to assess airway mucus plugs visually, and they found that 58% of subjects with asthma had mucus plugs. So here, this is the mucus score up to 19 is every segment affected. And then only 4% of the healthy subjects had mucus plugs. So there was a marked difference here. And the higher your mucus plug score, so here the higher are in orange, there was lower lung function, so lower FEV1, lower FVC, and lower FEV1 over FVC compared to normal or people with zero. Sorry, it's not normal, even asthmatics with zero mucus plugs. And then not only was it related to lung function, but also with eosinophilia peripherally and eosinophil peroxidase levels on BAL. And this is the mucus score category and eosinophil peroxidase levels, so showing that it's higher in those with more mucus plugging. And then just to mention that they did do a 3-year follow-up, and change in mucus score, an improvement in mucus score was linked to an improvement in FEV1 in these subjects with asthma. So we think a really important imaging finding. And then the pulmonary vasculature. So also in SARP-3, 237 scans were analyzed for vascular volumes. This is work by Sam Ash. And Raul San Jose Estepar and George Washko, of course, too. This is just showing the 3D reconstructions for the healthy normal subject and then a subject with asthma, where I hope you can appreciate that there's just less of this like orange and red. These are color coded by size of the vessel, but these smaller vessels are just missing. And so we describe this as pruning because I think that's helpful and understandable compared to here we have the BV5 over, that's the small vessels over the total vessel volume. And the lower this value, that's more pruning. And so here that's a lower value in severe asthma compared to non-severe asthma and compared to healthy controls. And so vascular pruning was associated with increased asthma severity, worse control, lower FEV1s, and more exacerbations. And then one of the follow-ups to this that Sam Ash looked at and using the cardiac volumes was wondering if that pulmonary vascular volume was also related to ventricular size. So this is a total ventricular index, and on a non-contrast CT scan, we're able to look at the outer volume of the heart, both the left and right. It includes the atria and the ventricle. And what they found was that in severe asthma, there was a lower total ventricular volume index of 36 milliliters less with severe asthma versus controls, and 14 milliliters less in mild to moderate asthma versus controls. And so this is a picture of severe asthma and representative cardiac volume. It's less than half. So this is just can be quite a marked difference in I think still trying to understand all of the implications of this. But the smaller ventricular volumes were associated with more exacerbations as well. 57% increase for those below the median compared to above. And so helium, hyperpolarized helium MRI has also been associated with lung function. Here's the FEV1 predicted on the bottom, and 3 helium, this is the ventilation defect percent quantified. And there's a correlation here in the whole lung. Those are the gray. The whole lung seems to me like it would be more associated with the FEV1, and then the regional ventilation defects percents are not as associated, but the correlation here is negative 0.61. And then for resistance of the airways on oscillometry, there's also a strong correlation here for the whole lung. The correlation is 0.77. So we think these are important measures. And people have compared, I like this study because it compares the hyperpolarized helium MRI and the functional small airways disease on CT scan. And so here we're showing a healthy control, someone with mild to moderate asthma and severe asthma. And this is the hyperpolarized helium MRI in the middle, and then the same section of the lung with the functional small airways disease and emphysema added. So they haven't colored the green normal lung here, but you can see that these yellow areas of functional small airways disease generally overlap with the areas that are ventilation defects, but not fully. So I think this more severe asthma, there's it's easier to appreciate that over here, this may be an area of more air trapping, but not ventilation defect. And over here, this area here may be more of a ventilation defect without as much air trapping. So there's some inter-subject variability, and this is actually plotting. So these are all low bar, the functional small airways disease percent and the ventilation defect percent. So plotting for each lobe of the lungs, how they compare to each other. And so there are a lot of outliers that don't fully agree. But one of the things that they noted that was interesting in this study was that in a number of cases where they don't agree, that they did see mucus plugs. And so is that one reason that you can have a ventilation defect percent here and not as much small airways disease? So you can visualize the mucus plug there. So then also, I think it's important to look at longitudinal outcomes. This study looked at 2-year exacerbation rates, and you can see that there were, this is in SARP also, I believe. But if you have one or more exacerbation, those patients had a higher ventilation defect percent after 2 years. And then higher functional small airways disease percent was also associated with more exacerbations. And the airway measures, wall area percent and luminal area, were associated with faster decline of FEV1 as well as persistent mucus plugs. In terms of therapeutic insight, so there are a few studies that have looked at changes in imaging after randomization to an intervention. So a lot of these are biologics. I've tried to include most of them, but this is a study of 61 subjects that were on mepolizumab or placebo for a year, and those that were randomized to mepolizumab had a decrease compared to zero. It would be zero change over the study period, but there was a decrease in the wall area on mepolizumab, as well as a decrease in the total airway area, in addition to seeing the reduction in the rate of exacerbations. This is just a study showing other measures is the total airway count, so the total number of airways that can be visualized on a CT scan. I did say they go into the hundreds. So on the pre and after the intervention, those on benralizumab had an increase in the total airway count, as well as a reduction in mucus plugs. And then here, these patients are on any anti-T2 biologic, and over time, there was a decrease in the ventilation defect percent in those on the anti-T2 therapy. And so then there are 2 studies that have looked at mucus plugs. This is the Cascade trial that looked at tezepelumab over 6 months period. And it's a really nice figure showing a universal decrease or stay in the same number of mucus plugs after 6 months of tezepelumab compared to placebo. And then the Vestige study looked at dupilumab over also 24 weeks. And what I think is pretty remarkable here, so these graphs are showing for the red is the placebo and blue are the patients who are on dupilumab. They also they did a CT scan at baseline 4 weeks and 24 weeks. And even by 4 weeks, you see a really marked decrease in mucus plugging on CT scan with dupilumab. And this is the only study I wanted to talk about. I know we're getting towards the end of the time. This on on the omics in asthma and imaging. So this study used, I believe, coined the term of radio multi-omics. And so they used unsupervised clustering in a severe asthmatic population. They clustered based on multiple quantitative CT variables. So this is just their graph of the clusters, but you may be able to see that the variables they used were the 856% if lung at 856, 950, the volume adjusted inspiratory scan. Here down, there's the wall area, the luminal area, and percent 15 or PD15 is another measure of emphysema. So they used about 15 different measures extracted from the CT scans to do clustering, and identified 3 clusters. And this was done in UBioPred, and then they replicated the clustering in Atlantis. And so these 3 different clusters were quite different in their clinical characteristics, which were not part of the clustering technique. So this group had more female, increased BMI, lower eosinophil count. And then the third category here, just to point out, they're more eosinophilic and lower lung function. And so this just shows they used the transcriptomics and proteomics from anything that was available in UBioPred. This wasn't done in Atlantis because there wasn't the same omics available, but it included nasal transcriptome, plasma, and you can see that there's differences across these three different clusters identified only on imaging in their the biologic activity of the lung or the subject. So differences in the complement cascade. Down here, there's differences in VEGF, a lot of cytokines, and I think this is just like the tip of the iceberg of what we're going to see in coming years. So I wanted to include it. So, in terms of conclusions, I think lung imaging holds promise in helping us understand more about the pathophysiology of asthma. Air trapping on CT and MRI and mucus plugging, I think, are some of the most sensitive intermediate endpoints that have been shown to potentially facilitate smaller and faster clinical trials. And I don't think it's quite ready to use imaging as personalized medicine in asthma, but maybe we'll be there soon. I do think it's important just to mention a few limitations that ionizing radiation has certainly its limitations, would like to limit it. So repeated studies in research and in clinical care are difficult for that reason. Imaging can be expensive, and many different techniques are only done at certain centers. So, like the hyperpolarized gas MRI is quite specialized and requires a specialized program to analyze the data too once you have it. And then the technology for image acquisition and then analytics is rapidly evolving. And so once you get set up to do something, it may become obsolete soon. And I just want to mention the photon counting CTs that are on the horizon, or actually here, just remarkably change how much you're able to see in the radiation dose delivered. So this whole talk may be obsolete in a few years. But I think that's an exciting thing about the field as well. So thank you so much for having me, and I will be happy to answer any questions at the end, probably. Thank you.
Uh, Carrie, thanks so much for that really nice talk, explaining that and giving us such a wonderful overview. I'm going to introduce Dr. Alejandro Diaz, who's an associate professor of medicine at Harvard Medical School and the Brigham Women's Hospital. And Alejandro has done a lot of groundbreaking research looking at developing imaging biomarkers to understand, diagnose, prognosticate, and intervene in airways disease. And he's done a lot of analytics in a lot of the NIH trials related to airways disease. Alejandro, thanks so much for joining us. Alejandro,
Yeah,
we can't
yeah.
hear
No,
you.
thank you, Elio, for your introduction, and happy to be here. And just my first slide of the disclosure here. I guess the main one is that I'm gonna focus on a phenotype we are working on in the last few years, which is mucus dysfunction in COPD. After the nice talk that overview that Carrie did, I think it is more limited in that way. And so here is my outline to cover today. And start with this problem about the mucus pathology in COPD and in this asthma. There's a lot of overlapping between the two airway diseases. Essentially, for us, as you know, smoking induces a lot of changes in the mucus, including increasing in production. The mucus become sticky, and there's reducing clearance because the smoking affect the ciliary apparatus. And then a big component of the mucus driving the changes is the high concentrations in mucins that are characteristic of COPD and other airways diseases like asthma and cystic fibrosis. And so, as Kerry pointed out, one of the things that we have done in the last few years, using the imaging to systematically evaluate this problem in people with in COPD. So you have an example there what that how it looks like when we look at those CTs. And one of the things that we use a simple visual analysis in the few years in the first few years we start with this, just counting the number of lung segments that are affected by this process. And the last few years, though, our scientists here, Raul and Pietro, developed this automated tool to detect this in a more efficient way. And is here you see example how these mucus plaque look like. You see the different sizes, different shapes, and they found a good correlation with the visual assessment we did, and now this work is under review. In the next few slides, or all the rest of the slides I will show you, is the data based on the visual analysis we start doing it, some years ago. And so one important aspect of this problem is that it affects all the airways. It affects the small airways, as you see this work back in 2004, showing that the luminal occlusion of those small airways, and when I say small airway, it means less than 2 millimeter in diameter, and the degree of occlusion is associated with lung function. So the greater the occlusion, the lower the lung function. And this was foundational to kind of confirm the concept that the main site of airflow obstruction in COPD is these small airways. Now, a year later, we start, as I said, looking at this systematically, and we found all this mucus plaque in people with COPD, as you can see here. So the question came, what we're seeing here on CT reflect what is going on in the small airways. And so here in this collaboration with Dr. Polverino here in the picture from Baylor College of Medicine, we look at the small airways on lung tissue in just 24 people, dividing people who have mucus plaque on CT, people who don't have mucus plaque on CT, using this amazing resource, which is the Lung Tissue Research Consortium, that are people who provide tissue, and when they go to a procedure, for instance, like taking a lung nodule out because it's lung cancer is suspected. And so what you see here in this panel is, in this panel B here, there is an increase in the mucins, MUC5AC, in those small airways in people who have more mucus plaque on proximal airways. The same thing here. This is caspase-3, is a marker of apoptosis, and you see also an increase, telling us about that also the repair mechanism in COPD, both those distal airways might be failing. And finally, here in panel D and A, you have a nice picture about what remodeling means in this black, showing here in this black line, in which you see that there is a remarkable difference in people who don't have mucus plaque. And you see here that plot as well. And the relationship with lung function, where higher modeling is associated with lower lung function. And here in G, you see a nice example of how a mucus plug in those small airway looks like. So I think this is good to kind of affirming that something is available for clinicians, like a CT scans, reflect something going on distally that we cannot see on CT scan. And so now I'm going to talk about the clinical implication of this problem. So one of them is that it's really frequent when we start this systematically, evaluating systematically this problem. So 41% to 46% in these two big cohorts. COPD gene is probably the largest COPD gene cohort in the US. With over 10,000 people. So, including people with COPD and without COPD, we evaluate all the people with COPD and found 41% on those subjects, and then 46% in the Eclipse cohort. The spiromic is another a great COPD cohort that also involves some controls, and 67% was there. You see some example how those mucus plug look like there. Then we also look at the over time in this small subset first, and we understand that now we learn that really a dynamic process, the formation of this mucus plug. You can see here that there are people that at 5 years still have those mucus plug. We call it persistent positive. People who resolve those, and other that came up with have this newly formed mucus plug at 5 year follow-up. And we also learned that it's more common in COPD compared to non-COPD, this phenomenon about persistent, and that also that the persistent is more seen in the lower lobes than in the upper lobes. And also we learned that it traveled very well with lung function, as saw in the lung tissue that prior as Elias before. Here we also saw that the prevalence of mucus plug increases with the severity of disease. GOLD is is a typical scale to grade COPD, and you see here that trend. And also in spirometry, they saw that the burden of mucus plug more often seen in people in those goal 3, goal 4. Think about if 1% predicted as less than 50% in goal 3 and even less than 30% in goal 4, just to have a magnitude what means these goal stages. And so another impact of this mucus plug is that when they are in different places in the lung, they affect the ventilation perfusion mismatch, making it worse. And so here, the resting saturation is lower in people who have those mucus plug, particularly when they don't have emphysema, suggesting that those occlusion contribute to the poor oxygenation, which is characteristic of this disease. I think Dr. Pistenmaa showed something about the Th2 inflammation phenotype in COPD. These have become very important in our in our part, because there's treatment there's treatment that is tackling Th2 inflammation, has been approved by FDA, reduce exacerbations and so on. So it's been very important in the last few years for clinicians to have a way to detect this Th2 inflammation by counting the eosinophils. And simply here I want to show you that people who have those Th2 inflammation phenotype have more odds to have mucus plug, as you can see here in these odd ratio numbers. And on your right, you have the we look at the two phenotypes, and we saw that there is an increase in the EFEV1 having true phenotype. Was not much different though if we having just mucus plug obstruction, which is, I think, makes pathophysiologic sense. But what's different though, when we look at exacerbation, having these true phenotypes, having EOS, high EOS, and mucus plug, you see that the odds for having exacerbation increase a lot compared to just having one of those phenotypes or none. And so I think why this could be important, because as Carrie mentioned before, there is a study coming on, and I think coming up to test this mucus dysfunction phenotype, and so this may help recruit patients, to select patients, or even to be an intermediate or endpoint for some trials. And other thing that is really important in this all this imaging stuff we do is that how they correlate with what is going on in the patient. So symptoms not tracked very well with Mucus plaque, 36% of the people who have those mucus plaque on CT don't report mucus symptom related cough phlegm. And you can see here the impact of having in those asymptomatic, we call it silent mucus plaque. The outcomes are worse in people who have those mucus plaque, even they don't have symptoms that you can see here, exercise capacity, quality of life, measure of lung function, and even structural measures. This was done by our fellow Dr. Medler. And I want to move into talk about three big outcomes in COPD that we linking with this process. One of them is mortality. As you know, mortality is a big COPD is an important contributor to mortality for all the respiratory mortality, and have been decreasing in the last 2 decades in the U.S., particularly because there is a more decrease in men, and so the gap between men and women has been lower in this century compared to at the beginning of. And so, and what we look at was, well, has any meaning this mucus plaque for mortality? And we found that people who have three or more have a high mortality compared to people who don't have those mucus plaque. In this COPD gene cohort, I told you before that have a median follow-up, 9.5 years. So I think that's important clinical outcome just to take into account how important could be intervene this phenotype. And here, Dr. Merle also looked at the specific causes of death, and we found that the mucus plaque are more related with respiratory causes of death, as you can appreciate here. And I think, and also unexpectedly with cancer. We don't know why cancer is associated with this, but I think it's important hypothesis generating finding that need to be a further research. And I think, for the respiratory part, as I'm going to show you, one of the notions that people have in mind for many years about mucus and mucus plaque in particular is that they are like a nidus of infection and inflammation. So triggering exacerbation, triggering pneumonia, that may end up, with the subject unfortunately dying. And so what we had data was for exacerbations, which are very important in COPD. Here, I think summarize that 50%, 70% of the direct health costs for COPD, reduced quality of life, require hospitalization, decreased lung function. We know that is causes mainly by infections, viral infection, bacterial infections, pollution is also a big factor triggering these episodes. And so we look at, in collaboration with Dr. Emily Wang here, we look at two cohorts, the Eclipse cohort, the COPD gene cohort, to see this link between mucus plaque and exacerbations over time. And you see here, there is an modest increase in those episodes in people who have mucus plaque. And she went further to look at this subgroup of people, like female, males, like BMI, with kind of category of obesity or not obesity, and current smoking stand, and so on. And if you see, you put your eye in your left and right, you see there's some consistency across these two cohort in the effect of this phenotype. So I think, again, highlighting how it could be important to see what's going on if we intervene. Finally, the lung function. Lung function, I think, was mentioned by Carrie before as well. But in COPD is an important consideration because people agree that is a hallmark of COPD progression. So if people is worsening, if it is one, things are not going well. And this study in Eclipse showed that there is a huge variability in these people in decreased lung function, but also some people with treatment when care keep lung function stable or even may improve over time. Here on your left, you have risk factors that have been priorly identified. So for us, was kind of important to see, particularly whether having this plaque blocking the airway over time has any effect on this, and we look at over 2,000 people in the COPD gene cohort at 5 years, and what we found here it was that those people who have persistent mucus plaque, as you can see here, in the yellow bar, had a higher decline in lung function compared to people who don't have those mucus plaque at any point in time. And in the C panel, it's important to see how important it is to quit smoking, right? So it reduces the effect of mucus plaque on the decline if you can. It's present there, but you see how important quit smoking is, how there is a huge difference here in these little bars compared with the rest, right? So move to trial. I'm gonna repeat. I think Dr. Pistenmaa nicely put this. I just remind that one of the pathways to increase the mucus production is the interleukin-3, and this thymic stromal lymphopoietin receptor can be blocked by this drug. Dr. Carrie Pistenmaa showed this. I'm not going to go over that, just to make the point that this is a visual assessment, right? And you see that a change of 1.7 degrees in this score that was described before. And here, one important aspect of this, and that's important to confirm these imaging phenotypes really confirm that is in the causal line of decrease in lung function, is that the group treated with the drug have the decrease of that mucus plaque have an increase in lung function, and also observed very shortly, which is important for us. This is why not. I don't know what's going to happen in COPD. It's a little more complex because there's emphysema, there's more damage in the parenchyma, so it could be different. But it's important to have this hope that it makes sense that increase the FEV1 lung function in this population. And so the question is, for instance, does another type of drug like mucolytics do something in COPD regarding this lung function metrics? And here you have the Vestige trial. The only point I want to make was the mucus plug was a secondary outcome in this trial. Even they put nice figure in the paper, but I think the important message here is that this was done with automated tool to detect mucus plaques. And so they provide two measures. Count here, you see the decrease of 3 points. And here is the volume of those mucus plaques. So it was about 120 milliliters decrease. So, and seen at 4 weeks. So what it means, we have now options to measure this outcome. Not only visually, we can be available for everybody in clinical CT scan. You can do that. And also, and more specialized centers might be application of other techniques like this one. And so, finally, my take-home message is that, yes, imaging pathology is important in COPD, and it's frequent, associated with bad outcomes, and we believe that the treatment may improve lung health, as shown in asthma, and hopefully we find something similar in COPD to help our patients. Thank you so much.
Thank you so much, Alejandro, and thank you so much, Carrie and Alejandro. So there are several questions that have come up. One question is, are there clinical symptoms that are more associated with the presence of mucus plugs? For instance, are patients with mucus plugs more, do they cough more? Do they have more shortness of breath? Do they, do viral infections affect these patients more? in asthma and COPD?
Yeah. So I would say, Carrie, you go well, after Miguel, in fact. I think the two things in our investigation, what we found the stronger association is with dyspnea. So people who have more mucus plug have more dyspnea. As I said, the correlation with cough and phlegm in general is not perfect. In general, I would say they tend to have more, but not necessarily. So people may have those silent mucus plug in terms of cough and phlegm. And so in terms of infections, it's really important question because we know that as a mechanism of defense, everybody who has a lower respiratory process, infectious one, increase the mucus production. And so in people who have disease, it might be that it is in the line of causing accumulation and then formation of this plaque. So maybe the result of and then keep it there. There's some biology that has been very nicely done to show why this is happening, why people keep those mucus plaque, and then that might be the trigger for the next exacerbation episode. So I think still we need to see what is the, maybe it's a bidirectional relationship. Carrier.
Okay.
Yeah, so that it's very similar to what it was seen in asthma in some of the studies I mentioned, but there's not a strong association with symptoms, more so exacerbations, but cough and mucus was not significantly different across the different categories of asthma. And, perhaps the lack of production of cough and mucus is one thing that contributes to the mucus plugging. So.
Another question. So, you both of you have shown these wonderful correlations and these new measurements. As you know, there are quantum developments now with using artificial intelligence to analyze radiological modalities, and such that one can now take a normal chest X-ray and develop calcium scores from normal chest X-ray, as well as even, I think, lung volumes and airway volumes. So when Carrie, you spoke about the kind of, CT and the radiation, how do you see this developing, and maybe even the question of whether we can move to something that's less non-ionizing in terms of like MRI, but using the greater ability of AI to kind of pick these things up?
I think there's potential for sure. I think when you're using things like X-ray on a large scale with large numbers of data points, I think the concern is just image quality and sort of separating the noise from the signal. And so, there are different degrees of inspiratory effort or scapula that are in the view on chest X-ray. There's just a lot of different things to consider. And I think one of the benefits on the research side when we do things like CT, there's really breathing, coaching of breath hold, and those are really important aspects of analyzing the lungs and looking for some of these subtle findings of air trapping. So I think there's potential, and when you have enough data points, can you find the signal anyways still? But I would just caution that there may also be a lot of noise.
Yeah. So I would like to add something. Yeah. That I think that the AI has all the potential to do all this stuff automatically, but the main concern is that having, first of all, whatever you do with AI is very specific and maybe not replicable. Can you not replicate that in other contexts? What that means is that when all this AI effort need to incorporate all sort of variation, geographic variation, all the people from all walk of life, um, different modalities, different techniques. of the imaging acquisition, so on. So you can see all these aspects, because if you do that way, you may have a more powerful AI thing for everything, will be for airway, for mucus, for emphysema, whatever imaging phenotype we want to measure with AI, it may be even more powerful if you have all these ingredients. The issue is that, well, people start, with things they have a hand. We have COPD gene scan, okay, but don't not representative of many things. So that is important, in the AI application, understanding some bias that it may have.
Thank you so much. We've run over time. Just to remind everybody, if you want to get CME credits, write to CPD, which is Continuing Professional Development. So cpd.partners.org, and then follow the instructions and write us if you have a problem. Thank you both, Carrie and Alejandro, for wonderful talks in the exciting use of imaging in airways disease. And everyone have a good day and have a good weekend. Take care.
Thank you.
Thank you. Have a wonderful day.